Today we're going to be talking about holistic nursing care in a critical care setting. I'm Paul and I'll be presenting with Marsha and Emily. So at the end here, we're hoping you'll pick up a couple concepts about spirituality and kind of how we handle that as nurses. To kind of start, even before we get into a definition, I had the opportunity to really experience this in a personal way on the 8th floor of the Brigham, which is kind of the surgical ICU, burns, and trauma. One of our patients, after a long battle with mesothelioma, last year had an extrapleural pneumonectomy. They basically took out her left lung in the hopes of stopping the spread of or metastasis of the cancer. She came back to us several times throughout 2012 and then again in 2013 she went to the emergency room with complaints of shortness of breath. She was transferred to thoracics, where it was determined she had a pleural effusion, and they really kind of hoped that it was all over. She had a chest tube placed, and they also drained the fluid via a needle. After the next day, she aspirated on her morning medications. Her SATs declined rapidly. Code was called, and she was transferred to the ICU, where we took over care. Unfortunately, it became very difficult. She desated as well and was intubated almost within 10 or 15 minutes of arriving on the floor, and was on mechanical ventilation support. She kept pace with the machine. She was sedated for a little while, and we stabilized her throughout our shift. The next day, I came back and had the opportunity again to care for her. Unfortunately, it was determined through a couple x-rays and also a culture that there was mesothelial cells on her right lung as well, and that it was evident that they had metastasized. Unfortunately, she was still having trouble breathing and was probably fluid overloaded at that point. And it became apparent that she would not be able to function very well without constant oxygen support. Her family, having talked to her before, her healthcare proxy, one of her sons, decided not to continue mechanical ventilation, and we switched to a non-rebreather, which she did well on, and eventually to just a full face mask. She tolerated that for probably 2 or 3 hours, and at which point she called one of the nurses over and her son and kind of talked about the fact that she was very uncomfortable. The mask didn't allow her to talk to her family, so she was taken off the mask and put on a high-flow nasal cannula. At that point as well, she and her son discussed continual aggressive treatment for the cancer, and at that point the thoracic surgeon, the ICU attending physician, and the nurses stepped out and had a meeting with the healthcare proxy as the lady became tired and needed to rest. And in that meeting it came out that they did not wish to continue aggressive procedures, and kind of made the choice, that it was really God's will, and that the machines were kind of getting in the way of God's plan for this patient. And at that point, it was decided that comfort measures only and symptom management was how she was going to be handled. And at that point, she was transferred to a hospice unit with full family support, and her feeling very confident in both herself and in her faith.
Great. So, as Paul's whole report kind of signifies, there is a real sense in critical care nursing of the physicality of a person, caring for the physicality. We're trying to keep them well, to restore their health. What is really interesting on each of our floors that we've found is that we work with great nurses who not only focus on keeping this physical health with all of the machines and the bells and thoracotomy and O2, but also in really trying to see the person underneath all of those tubes and connected to those machines. So this screen just gives a definition of holistic nursing. It's of note that holistic nursing is recognized as an official nursing specialty in 2006 by the American Nurses Association, and it does have its own defined scope and standards of practice. So there are 4 domains of treating the whole person, and this comes from a research article from Critical Care Nursing Journal. And of the 4, we have physical, mental, social, and spiritual. It's noted that the spiritual domain is the most neglected, and I think this is something that we've seen in our practice, is that it's sort of seen as something great if you can have the time to do it, but it's not something we really report on. It's not something we put in our nursing notes in general. And so we're hoping this report just shows that it can be very important to a patient, and it can be very important to their healing process. So as we begin, just to give a definition of what we mean in this report by the word spirituality, it's really a very broad definition. So it includes organized religion, and it extends to really the person's own beliefs, whether that's atheism, the idea of being spiritual, and the broad definition that was given in the research is all behaviors that give meaning to life and provide strength to the individual. Of note here, nurses are responsible for assisting the patient to adjust the meaning for life alongside an illness. And you can imagine that what that means is getting to know your patient and helping them form this narrative of how this illness that they're experiencing is going to fit into their life and fit into their future as they heal. And spiritual assessment, again, not something in our flow sheets, but it really does matter that as a nurse, we can come into a room, and as we're looking at the vital signs, as we're looking at listening to lung sounds, oscillating the heart, we're also looking at the person in that bed. And the idea is similar to culturally competent care in that this is an individualized practice. Room 4 is going to be completely different than room 12. We have to meet those patients where they are. In addition, we have to know what our own biases are, and we have to be able to know what we're prepared to do for each patient and be very aware of what we're saying and how we're acting with each patient. And just continuing with this idea of a spiritual assessment in terms of what is it, it can be as simple as talking to your patient about religion. We're in the room, we're doing a dressing change, a great time to talk. We're helping them with some ADLs, just seeing watching what sorts of things they do in their family visits, speaking with them about it. And of course, as always in almost all nursing care, it's critical to build that trust and that rapport with our patients.
And then just bringing in the evidence-based practice. So this is just mentioning how the nurses are in a position to safeguard the wholeness and integrity of the patient. So like Emily said, we're looking at the whole person, not just the illness that they have. And an article in the Journal of Clinical Nursing found that there's a positive correlation between spiritual care perceptions and spiritual care practices among nurses, which basically means that if a nurse has spirituality herself, then she's more likely to provide spiritual care to her patients. And we'll find that spiritual care is very beneficial for the patients oftentimes. The same article talked about how the influence of spiritual care is beneficial, and that it would be beneficial as a whole if the nurses were able to spend more time with the patients and fulfill their spiritual needs. But like most of us have experienced, there's very little time where the nurses are able to spend just chatting with the patient, and it's mostly focused on the acute illness at the time and the procedures that they need to do. So this is just reinforcing that the spiritual needs are still important. A nursing diagnosis is spiritual distress, and it's basically defined when a patient has an illness that separates him or her from his or her spiritual centers or supports. And you might see it in a patient presented as the patient thinking that he or she is sinful and they're here because they deserve it. They've lost faith. They're wondering why it's happening to them. And then they aren't able to practice their normal religious rituals, which can be very upsetting for them and can often delay their healing. Our case study is pulled from the literature, and it talks about RV, who is a 17-year-old male who's diagnosed with acute myeloid leukemia. His history of presenting illness is that he was diagnosed, and then he received a stem cell transplant 4 months later. And then he relapsed 4 months after that and spent 2 months in the hospital where he received aggressive treatment. And during that time, his nurse reported that he experienced a lot of sadness and frustration, but he really wanted to keep fighting and was willing to do whatever it took to beat his cancer. He ended up developing an infection, and his leukemia progressed further, and then the medical team started talking about comfort measures only. So to assess a patient's spiritual suffering, you want to talk to them about what their definition of spirituality is and what are their beliefs about life and death. Are they searching for a meaning and purpose within their illness and their dying experience? What is their self-awareness or knowledge of an inner being? And are there any cultural or religious practices? Other factors to take into account are the patient's cognitive ability, the patient's ability to experience pain, and how do they experience pain or emotional symptoms. How are the family members coping, and what are their ways of coping? And any cultural or religious backgrounds and social supports. And then you want to assess the patient's verbal and nonverbal cues that may indicate spiritual suffering, such as facial expressions or if they're having any dreams. They may ask about, what is dying like? I can't believe this is happening to me. They may mention that they want to leave a mark, and they want to make sure that their life has made a difference to someone else's life. So to manage spiritual suffering, the goal for the nurse is to facilitate the patient's encounter with spirituality issues related to their dying. So to do that, you can involve professionals with expertise related to spiritual and existential issues. You can conduct regular explorations of spiritual concerns by just asking them, what are they going through? And you want to identify if they have any religious background and facilitate community and individual support. And then, of course, you want to continuously reevaluate the patient's spirituality. Is this mic still? So for nursing interventions, you want to be open and receptive by active listening, allowing the patient to voice any doubts or concerns, encourage the patient to vocalize practices to better respect routines, which might include praying at meals or during certain times of the day, and then be knowledgeable about spiritual resources, such as those professionals who have expertise in spiritual and existential issues, or any clergy members, and stuff like that. And then, of course, just encourage the patient to continue their religious practices during the illness if it's useful for them. By the end of the case study, RV ended up dying. He battled cancer for 1.5 years, and he was able to spend his last 6 weeks at home with his family and friends. His nurse, who he had many deep discussions with, encouraged him to discuss with his mother any life goals and final wishes he had. And then many of them were able to be fulfilled, and he was able to plan his own funeral, for example. And he also left letters behind for his parents. So for him, it was very helpful to have the spiritual guidance from his nurse.
So evaluating whether spiritual needs can be met is tricky. There's no spiritual, score where they rate it 6 out of 10 for how well you've met their needs. So really the outcome or evaluation is pretty nebulous. It's, will they be able to meet with someone of their religion or someone that can help them define their, how their illness relates with their spirituality, or will they be able to verbally tell you, I'm in a better place? And that's pretty difficult to do as a nurse, especially if you're unfamiliar with, certain religious practices, or with, their just general state or their own definition of spirituality. This is why, a thorough examination of your own levels of, spiritual well-being is extremely important to deal with patients that are suffering from spiritual distress. I'd like to point out that the World Health Organization, takes on the idea that health is way beyond just, not being sick. It encompasses this mental and social well-being that spirituality feeds into, and, your patient may be asymptomatic while they're laying in that bed, but who knows how much they're really missing being able to say that rosary, or, being able to pray on a prayer mat. So it's really kind of the nurse being proactive and, using probing questions to find out how well they're doing internally. So really, this article from Campbell talks about how important spirituality is on handling an illness, or on handling stressors in everyday life. So it kind of shows that nurses who are spiritually competent experience perhaps less stress at work because they do have kind of a fallback network. Even beyond, this kind of transcends the patient and focuses on the caregiver here, that it is important to have a spiritual or religious community to fall back on and draw strength from during periods of stress, or maybe during a difficult illness or a connection with a patient that you lost. Thailand kind of offered this model where nurses that are dealing with death and dying incorporated relaxation and meditation, which are kind of go along with the idea of fostering spiritual growth and really examining how you're doing as a person. So our conclusion here is basically that a nurse will be able to accurately assess where a patient is at and recognize interventions here, whether the assessment is flat out having them check a box on their admission, or if it's maybe day 2 or day 3 in their admission, then you've developed that rapport and you can say, I noticed you use prayer beads. Is there particular times? So building rapport, or maybe checking off a sheet. And once again, that's going to vary from patient to patient, and all depends on really how comfortable the caregiver is with their spirituality and approaching others about that. The intervention we talked about are kind of like what we learned about in psych, where you're actively listening, you're asking open-ended questions, and you're really putting the focus less on how you practice spirituality and on how the patient practices. But it's also important that the caregiver kind of looks inside and realizes that, boy, I have my own spiritual network outside of, a hospital or a healthcare place that I can fall back on if I'm really having, a rough day or a rough patient here. And it's also recognizing that, I kind of have to leave my judgments at the door. For example, the patient I talked about with mesothelioma, if the family said, what, comfort measures only isn't an option, we want to fight this out, that I'm sure personally I might have questioned that, and I'm sure several members or of the healthcare team may have questioned that. But at the same time, you have to recognize that part of their religion is that it's do or die here, and die is not an option. So holistic nursing is a part of the physical symptoms, but at the same time, particularly in death and dying or transferring to hospice or terminal diseases, it becomes a little bit more than symptom management and becomes a focus, ensuring that the patient is, completely healthy beyond the absence of disease or malignant symptoms. So here's a couple of our references. We've sent hopefully 2 articles attached to this email. If not, we'll send another one. And then here's a critical care, the American Association of Critical Care, and kind of their themes regarding spirituality.